Most of you here know a lot about it already, so I won't spend much time. The reason why I have that in my slides is because, just as a reminder of when we're giving medicines, what are we treating? What are the symptoms that we're treating? What can we expect? So that's why I talk a little bit about that. I divided it up in medications for what we call motor symptoms, and then medications for what we call non-motor symptoms. I'll talk a little bit about what's new, what are the newly approved medications, and then I do have a slide about what's currently in development. So what are people looking at? What can we expect from research? So real quick, and again, most of you know this already, so motor symptoms, when we talk about motor symptoms, we talk about stiffness, we talk about slowness, we talk about tremor, we talk about gait instability, balance problems. So those are the main things that we're talking about, and those are the main things that we're trying to target with the motor medications. There are a lot of non-motor symptoms too, and they're very important too and often overlooked. So if we're talking about that, we're talking about and this is just a list. There's some other things too that I left out, but the main symptoms that we're looking at are memory problems, dizziness, which can sometimes be related to low blood pressure, depression, anxiety, very common, constipation, very common, other things like drooling, urinary problems, sleep disorders. All of this can be part of Parkinson's also, and we do have treatment for some of this. As a reminder, this is also something that I put on here just for a little bit better understanding about what the medicines are doing. You hear a lot about this brain chemical called dopamine. That's the main kind of brain chemical that we're trying to target currently with Parkinson's medications. The reason for that you'll see here. So on the left, you see somebody that does not have Parkinson's disease. This brain chemical dopamine is produced in nerve cells in the brain stem in an area called the midbrain, and you can see here on the bottom left there's a nice black substance, or we call it substantia nigra. That's where the dopamine is produced. And then up here you see a brain scan, a PET scan, and it looks at something called fluorodopa uptake, so it has something to do with dopamine. And this is nice and red here, and that's what it's supposed to look like. Now, in Parkinson's, it's not as nice. So we see the uptake is not as good on the brain scan, and we see here it's pale and not as nice and black. So we have less production of dopamine. We have less nerve cells that are producing dopamine. And that's one of the areas that medications are trying to target. So I won't get too much into details, but again, for a little bit of an understanding, what are the medicines doing to me? What are we trying to do here? This is, imagine zooming in more to the nerve cell. So a nerve cell, a little bit simplified, has two parts. One is the presynaptic, and then the other area is the postsynaptic part. And so what's happening here in this nerve cell that produces dopamine, dopamine is released here and then binds on the postsynaptic area and then takes action. So I'll go back to that because different medications work in different areas of this nerve cell. And I don't expect you to remember any of this, but it's just for a little bit better understanding. So these are the main currently available Parkinson's medicines that we use for these motor symptoms. And you see here, the first 4 groups of medicines have something to do with dopamine. So still the majority of the medicines we're using have something to do with dopamine. There's one group on this side that is not directly involved with dopamine, and I'll get to that later. So I want to talk about these groups one at a time. The main one, and that's why it's listed here as the first medication, and I'm sure most of you have heard about it or even take that medicine, is the carbidopa levodopa. It's been around for a really long time, over 50 years. Although it's been around for that long, it's still our most effective medication. And we still use it as a gold standard for the treatment of Parkinson's. The active ingredient is the levodopa. And then the carbidopa is kind of coupled with the levodopa. It blocks an enzyme and reduces side effects. So if you were to just take the levodopa, you get really sick. You start throwing up. And so the carbidopa helps with side effects. So I want to go back to the previous slide and kind of show you what it does here. So the levodopa basically replaces the dopamine right here. You take it, it's in your blood, it gets taken up, and some of it ends up in the brain, and it's taken up here, and it basically replaces the dopamine that people with Parkinson's are lacking. So that's what it does. There are lots of different formulations of the carbidopa-levodopa. The most common one is the Cinemet IR, or immediate release Cinemet. That's the one that we like to use for dosing during the day, sometimes at night if needed. It doesn't have a very long half-life, so often people end up taking it multiple times a day. We started with 3 times a day, but a lot of people take it much more often than that. There's a different formulation called Cinemet CR. That's a longer acting formulation. It's usually a bigger blue-purple pill. The problem with that is that absorption is not always very reliable, so I often don't use it for daytime dosing. We do use it at bedtime sometimes if people have problems at night. They wake up with a tremor or feel really stiff in the morning, so that can be an alternative for that. Another formulation is the Stalevo. It is also carbidopa-levodopa, but it has a third ingredient, which is the entacapone, which can help make it last a little bit longer. I'll get to that in a second. Parcopa is also carbidopa-levodopa. It dissolves under the tongue. So sometimes if you have swallowing problems or problems with chewing, that can be an option. Rytary comes in a capsule. It's a little bit newer. Again, it's also carbidopa-levodopa. It's the way it works, it's a little bit different. There's one part that's released immediately, and then one part that's more of a delayed, controlled release part. So the idea is that it can help last longer, but ultimately you end up taking it quite frequently as well, and it's more expensive. Duopa is also carbidopa-levodopa. What that is, it's a gel form of carbidopa-levodopa, and it's given with the help of a pump and directly into the small intestine. So you need a tube for that, you need a pump for that, and it's only for certain people that would benefit from that. So not everybody ends up with that pump, but that's available if that's beneficial. Low dosing is not carbidopa-levodopa, it's just carbidopa. So we use it for people that have a lot of side effects, a lot of nausea, for example. That's when we add it on, so it can help with that. So what does it do? It helps with motor symptoms. So it helps with stiffness, slowness, tremor. It can help with walking. And again, it's still our most effective medication. Side effects, all these medications have side effects, and a lot of them are pretty consistent if you look through these different medications. But for this one, for the carbidopa-levodopa, nausea is definitely one. Dizziness can be due to a reduction of blood pressure. The one that a lot of people are worried about is the dyskinesia. So those are the extra wiggly movements. That can be a side effect. Sometimes it can happen after years of taking it. Sometimes it happens with higher doses. It can happen earlier on too. But because this medicine has been around for so long, and we have lots of long-term follow-up study. There was a study a couple years ago that was published looking at patients for 10 years, following them, and it turns out we can deal with dyskinesia. We can change frequency. We can change dosing. At the end of 10 years, people tend to have a higher quality of life taking that medication earlier on rather than waiting for a longer time. And there are other side effects too. Hallucinations, for example, can be one too, usually in people that already have problems with that or memory problems. But again, we'll still use it quite a bit. Most people with Parkinson's at one point or another will end up on that medication. We do have other medications too, so I want to talk about them. The next group, they're called dopamine agonists. And this kind of goes back to what are they doing? So they don't work in this part of the nerve cell. They work here. They bind on dopamine receptors and kind of pretend like they're dopamine. So the mechanism of action is a little bit different. Examples of that are ropinirole, pramipexole. They both come in a short-acting and a long-acting version. Retigotine comes in a patch. And then apomorphine is an injection that's used for rescue off time. So people that are frozen, occasionally that's something that could be used. It's an older medicine also. They all have the same side effect profile, so they can also cause dizziness, they can cause nausea. More specific, and with higher doses, they can cause sleep attacks, so we don't want that to happen when you're driving. That would be a big concern. So falling asleep all of a sudden, that would be very concerning. And then the other thing that you hear about is problems with impulse control, so people that start gambling, online shopping, so that's something that can happen. Certainly not everyone, but we know that can be the case. What does it help with? Same thing, it helps with motor symptoms, stiffness, slowness. Can help with tremor. It can help with wearing off symptoms, so kind of in addition to the carbidopa, levodopa, if it doesn't last long enough. So those are the kind of indications that we're using this for. And then the next class are the MABA inhibitors. So again, just kind of looking at what do. They block an enzyme so that the levodopa, that the dopamine that's there is kind of preserved in this area here. There are milder medications, so again, can help with motor symptoms, but not as much of an effect compared to the levodopa and the dopamine agonists. Examples are selegiline, that's been around for a while, that's metabolized to an amphetamine and can have a little bit of a stimulating effect. Rasagiline is another one. Sulfonamide is one of the newer ones that has an MAOB inhibitor function, and then it does something with another brain chemical called glutamate 2, but I did put it in this class because it's related. It can be used as an add-on. It can be used as a very early medication. Again, if you have severe symptoms, that's probably not just the only medicine that you want to be on. It's pretty well tolerated, dizziness, headaches, there's some other side effects. You may hear about interaction with other medications. Antidepressant medicine, your pharmacist may call you and say, be careful with that. There's a higher risk of something called a serotonin syndrome. So we'll look at all of that, but it's just, that's one option. The other class is, they're called COMT inhibitors. They also block an enzyme, so they kind of work in this area here. They help the dopamine last longer and hang around longer, so they're used for wearing off symptoms. And examples, the main one is the entacapone, and that's part of the Stalevo. There's one other one, but we don't really use that much because it can cause liver problems, and so I don't think I've ever prescribed that. Side effects can enhance any side effects that carbidopa, levodopa has. It also causes discoloration of the urine, the entacapone. So that's kind of an add-on. It only works when you take it with the carbidopa, levodopa. So those are a lot of medicines that have everything. They all have something to do with dopamine. And then the other one, the other class is the non-dopaminergic medication. One of the main ones is probably amantadine. That's been around for many decades too. I'll talk about that in a second. There's some updates about that. We mainly use it for dyskinesia, so these wiggly movements, it can help with that. It has an anti-Parkinsonian effect also. Side effects, again, nausea, dizziness, hallucinations, constipation, dry mouth can be side effects. And then the last ones that I rarely use are the anticholinergics. So examples would be Artane or Cogentin. They were used before the carbidopa, levodopa is available. Can help with tremor a little bit. Can cause a lot of cognitive problems, memory problems. So dry mouth, constipation also. I rarely use those medications, but they are available also. All right. One thing that I wanted to add about carbidopa, levodopa is that often when we start it in the very beginning, it has a nice effect, and we have kind of a steady state throughout the day, so symptoms are controlled. But as time goes by and the disease progresses, we see a lot of ups and downs. So you take your medicines, it takes a while to kick in, 20, 30 minutes, you're stiff and slow, then it kind of goes up. Maybe you're dyskinetic at the peak, you get wiggly, you're okay for a while, and then it kind of goes down, you're stiff and slow, you have wearing off symptoms, you're kind of chasing it during the day, and so that is something that we call motor fluctuations, and we can work with that. So again, we can change timing of medication, we can change dosing, we can add medication, we have surgery. So there are some things that we can do about it, but certainly something to keep in mind that we're dealing with occasionally, and certainly more the longer the disease goes on. A lot of questions about interactions and interactions with food, and most of you may know this too. The main things that I wanted to point out is one is the carbidopa, levodopa. It is a protein building block, and so it competes with absorption of protein. So if you eat a big steak, fish, cheese, anything that has protein, absorption in the stomach will be slowed down. It's not that you don't get anything, and you still get there are a lot of people that still get enough, but if you want to have a good effect, often it's better to take it away from meals. In the beginning, when you first start taking the medications, I often tell people to take it with food because it also helps with side effects, so nausea, dizziness. And then once you're okay on it, you can start taking it away from food. But you still need your protein, so don't think you shouldn't be eating protein. You need a healthy, balanced diet. And that can be tricky sometimes. If you take your medicine several times a day, you think about when to take your medicines, when to eat. And so that's always a kind of an up and down thing that we have to work on. We can work on it, but it's certainly something to keep in mind. The other one is the MABA inhibitors, so that's the rasagiline, selegiline. They increase something called tyramine, and that can elevate blood pressure if you eat something that has tyramine in it. So that would be red wine, beer, some cured air-dried meats, and fish, aged cheese. There's some other things. And again, it doesn't mean that you can't eat any of this. It just means that you should eat it with moderation. And a lot of times it's not a problem. But again, just something else to know about. And this is specific to the MABA inhibitors. All right. Okay. So I'll just keep going. We can answer questions in the end also. But again, stop me if you have any questions now. So we talked about the non-motor symptoms. I'm sorry, about the motor symptoms and medication for motor symptoms. I did want to spend some time talking about non-motor symptoms because, again, they can be very disabling, and we do have some medications and some things that we can do to help and use to help. So one is low blood pressure, or something called autostatic hypotension. So you get up, you stand up, your blood pressure drops, you get dizzy. A lot of people fall. Some people don't even feel dizzy, but they still fall because their blood pressure drops. So what do we do first? We look at medications. We make sure you're not taking medicines that increase your blood pressure. Sometimes we reduce the carbidopa, levodopa, because that can also reduce blood pressure and cause dizziness. We look at fluid intake. Sometimes compression stockings can help. Increase in salt in your diet can help. But we do have medicines available too. The midodrine and the Florinef are the ones that have been around for a while. So what they do is they increase your blood pressure. Florinef can cause some swelling of your legs. Both, especially the midodrine, what they can do is they can really increase your blood pressure when you're laying down. So we always have to check blood pressure in different position. The newer one is the Northera droxidopa. That was FDA approved a few years ago now. It's more expensive, so sometimes not used as a first line, and limited long-term studies, but it's been around in Asia for a while too. So those are the three medicines that we use to increase blood pressure if needed. Constipation is another problem, very, very common, and a lot of these things that people try out over the counter, like stool softeners, other things, milk of magnesia, increased fiber intake, fluid intake, activity, exercise can help too. Miralax is something else. It's a struggle sometimes. Not everything works for everyone, but there are, again, some things that we can do and use to alleviate that a little bit. Depression, very common in Parkinson's, common in the general population, but especially in Parkinson's also. There are some studies looking at specific antidepressant medications, so paroxetine, venlafaxine are the ones that have been looked at, and they were effective, but there are other antidepressant medications too that can be used, so it doesn't have to be one of those. This is just a continued list of medications for non-motor symptoms. Cognitive problems, so memory loss. There's a medicine called rivastigmine that's been used for Parkinson's dementia, but there are other Alzheimer's medications that we use also. Hallucinations is something that we see. I got a lot of questions about a commercial about Parkinson's and hallucinations, and it wasn't clear that was actually from a drug company, but there's this medicine called Nuplazid that can help with hallucinations in Parkinson's. You may have heard something about increased mortality with this medicine, but most people think right now that it's just an increase in mortality in that population to begin with, and it's not necessarily the medicine doing it. So people are looking at that. Clozaril is effective. The problem with that is that you have to have frequent blood draws because there's a risk of a problem with your blood count. So the blood count has to be checked very often in the beginning, and then later on still. The third one is Seroquel or quetiapine. One of the benefits with that medication is it can help with sleep. So people that sleep better seem to have better cognition and also possibly less hallucinations. And then the other part is reduction of your Parkinson's medicine can help with hallucinations also. I don't know if I need to go through everything here. I know it's getting a little bit long. There's sleep disorders. There's something called REM behavior disorder. We use a medicine called clonazepam. There are medicines for drooling. We also use botulinum toxin injections for that in the salivary glands, which is quite effective. Urinary problems, there are a few medicines, and again, I'm happy to talk about them later too, more in detail, but I want to keep it a little bit more interesting. Urologists also use Botox injections for certain indications of bladder problems. Just know that there are things that we can do outside of just the stiffness and slowness. All right, what's new? We talked about the one medicine being around for 50 years. It's still our most effective medication. That sounds pretty depressing. So some people say, why don't you come up with something better if you've been using this for decades? What else is out there? And so if you look at this list, I wouldn't say anything groundbreaking. A lot of it still has to do with dopamine. Rytary is, and I just briefly mentioned this, is one of the newer formulations of carbidopa, levodopa. Duopa was the pump that I talked about. Also newer on the market, the droxidopa for the orthostatic hypotension. This was the hallucination medication. Sulfonamide, also a Parkinson's medicines. All these medications were approved in the last 5 years, 2 to 5 years. For Parkinson's, and then there are new formulations of amantadine to long-acting formulations that were also recently approved. Again, nothing groundbreaking because we kind of knew these medicines, or at least half of them, we knew them already in different formulations, but those are the newly approved medications. Now, there are other approaches, though, and so I just wanted to share that with you. There is a lot of research going on in Parkinson's, and this is just a selection. This is not everything that's currently being done. What I listed here, it doesn't mean that it will actually end up on the market, but those are things that are currently being looked at. So this medication, or let's start with this group. So a lot of times researchers look at medicines that are already available, and they see, well, maybe it works for this, but maybe it works for Parkinson's too. So examples would be some diabetes medicines that were looked at in the past, and here's a group of other medications too that are already available for other things, so they're looking at it in Parkinson's. One is a cancer drug, one is a high blood pressure drug, one is a nicotine patch. So those are the examples of medication that already exist, and they're being tried on Parkinson's. A very big area of interest is something called alpha-synuclein. That's a protein that we all have in our brains. We don't know exactly the function, but we know it has something to do with Parkinson's. We know it has something to do with the Lewy bodies that we can see in the brains of Parkinson's. So that's being looked at as a target or potential target. There's a vaccine that's being studied. There's an infusion, which is basically an antibody for alpha-synuclein. So those are things that are currently being looked at in studies. And then, since again, the carbidopa, levodopa is our most effective medications, people are looking at other ways to give it to the patient. So there's a different pill that kind of sticks to your gut, the accordion pill, subcutaneous levodopa that's being looked at, and then also inhaled levodopa, and that will be used to improve off time, so it works pretty quick. There are some other approaches too, so that's not the only thing, but those are probably kind of the highlights of research what's currently being done.